You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 22nd, 2019. This week, I'm going to talk about the ischemia trial, Impella, asymptomatic aortic stenosis, colchicine, and treating to target LDL after stroke. These were all studies that were presented at the American Heart Association meeting. But first, an announcement. Next week is Thanksgiving, and This Week in Cardiology will be taking a week off, and I'll return the next week after that. Next announcement, I want to say thank you to all of you who came up to me at AHA and said that you listened. This means a lot to me. I want to say a special shout out to the young doctor from Kyrgyzstan who approached me. Again, the power of social media is amazing. I really appreciate your listening all over the world. Now to the ischemia trial. At American Heart, Professor Judith Hochman presented results of the most important trial of my career. The ischemia trial, call it the final test, if you will, of the clogged pipe frame of heart disease. For my entire career in cardiology, people have worried about having stable lesions in their coronaries. What if this thing closes down? We think this because of the ocular stenotic reflex. Once you see a blockage, you cannot unsee it. Well, over the past decades, our brains have been playing two movies. The rational movie is the side that knows every single trial of PCI as an add-on to optimal medical therapy. The COURAGE trials, Berry 2D, the meta-analyses of all these trials have shown that MI and death are not reduced by placing a stent. Our rational brains also remember that the CABG versus medical therapy RCTs were negative, other than a small subgroup with left main or triple vessel disease. By the way, that was in an era of medical therapy well before high-potency statins. But our rational brains are only part of the story. The other part of our brain feels the risk of having that LAD stenosis. You know, what we call the time bomb. What if it were I-frame? So in the cath lab, the theater goes like this. After a stent, the doctor gathers with the patient, family, and staff, and he or she shows the before and after pictures. And literally everyone feels relieved that the gnarly blockage is fixed. Now, while some of my online colleagues proclaim that the COURAGE trial changed practice, and then patients did not get cath and PCI after positive stress tests, I'm here to tell you, in my world, people with ischemia go to the lab to define their anatomy, and they often get a PCI. This is normal practice. Now, the prevailing reason for essentially ignoring the COURAGE trial was that PCI proponents say that doctors did not allow their sicker, more ischemic patients to get randomized. COURAGE was negative, therefore, because these were lower risk patients. The scary patients got fixed and not put in the trial. Well, the $100 million ischemia trial addressed these concerns. More than 5,000 patients with documented ischemia, documented by a core lab, by the way, were randomized to PCI plus OMT, optimal medical therapy, versus medical therapy alone. The investigators did a blinded coronary CTA to test for screen failures. That is, those patients who did not have disease, the false positive stress test, or those that had left main. This means the ischemia trial was enriched with patients who had significant coronary disease. In fact, 86% had moderate to severe ischemia based on their stress imaging procedures. Note that there are arguments about the threshold being too low. In other words, they should have required a 20%, not a 10% ischemic burden. And I understand that reasoning, but this is still a population enriched with a degree of disease that is routinely treated with revascularization in most centers. Now, you already know the primary endpoint. It was a composite: MI, CV death, hospitalization for unstable angina and heart failure, and resuscitated cardiac arrest. And the results were negative. The hazard ratio for the primary endpoint was 0.93. Major secondary endpoints of CV death, also non-significant hazard ratio of 0.90. The authors did a Bayesian analysis on overall death rates and wrote, quote, the probability of at least a 10% relative risk reduction of the invasive approach on all-cause mortality is less than 10%. There was no heterogeneity treatment effect based on any characteristic. Judith Hochman made the point that patients with 3-vessel disease did have higher event rates than patients with 1-vessel disease, but, quote, nevertheless, there was no advantage to the invasive approach. Now pause for a moment and think about that. So ladies and gentlemen, I think this is it. The final test showing that Dr. Bernard Lown was correct back in the 1970s. Chronic coronary disease is a stable disease that can be managed medically. While 23% of the medical arm crossed over to revascularization, that means that more than 3/4 of these patients with significant coronary disease, did not receive an intervention. This is remarkable, and it shows that opening clogged pipes is not the best approach. It shows that focal stenoses are a mere surrogate for the larger disease of atherosclerosis. I wanted to make a comment about the angina relief report. As I wrote in my preview, this was positive. Of course it was. It would be so in an open label trial. Now, there were some comments made during the presentation that the signal of angina relief would have to be real because it was seen out to 3 years, and the placebo effect wanes. Now, I don't know of any evidence that the placebo effect wanes, but let me tell you what Dr. Sanjay Kaul from Cedars-Sinai said to me via email. He said that the secondary endpoint of angina relief is possible noise, even though it's plausible and consistent with prior evidence. He said the open label design introduces a bias of expectation, the placebo effect, which is not fungible with time. Placebo effects are based on knowledge of receiving a stent, which are expected to relieve angina. This knowledge is not expected to fade with time. So, this is still Dr. Kaul writing. If Dr. Spertus, who presented the quality of life trial, claimed this was not a placebo effect, then he must know something about the elusive science of placebo effects that I am not aware of. A final comment on the CTA issue, and I'll talk more about this in later podcast. One doesn't need a CTA to rule out left main disease in clinical practice. There are often clues from the stress tests like exercise duration and blood pressure response, etc. The only reason CTA was implemented in ischemia was to address the equipoise and ethical issues. Venk Murthy from Michigan has reminded us that CTA could have made a difference in only a minority of patients. For now, I'll give you Sanjay Kaul's comment on the CTA. He said the fact that CTA is emerging as a winner from this is unwarranted hype. The trial was not designed to test CCTA versus no CCTA. Moreover, coronary CTA did not facilitate identifying those who would benefit from PCI or OMT. CTA enabled the patients to be randomized after left main was excluded, so it addresses only the equipoise issue. I am personally very concerned about the expansion of CTA use will lead to more angiography and PCI. Of course, I know that CTA shouldn't start an angiography cascade, but remember, until our rational brains, the part of the brain that knows that coronary artery disease is not a time bomb, takes over and dominates the fear side of our brains, having more CTAs out there will, I think, lead to more angiography and PCI. Second topic is a subtopic of ischemia, and that is the ischemia CKD trial. Andrew Foy from Penn State University explained to me that the results of the ischemia CKD trial offered an important lesson on how multimorbidity influences treatment effect. So we know that cardiovascular disease is one of the main causes of death in patients with chronic kidney disease, CKD. The question then is whether CKD patients, a much higher risk group, would benefit from the invasive approach, and it clearly did not. Despite a nearly threefold higher rate of events and strong methodologic efforts to limit the amount of contrast-induced kidney injury, the ischemia CKD trial found no difference in the primary endpoint of CV death or MI. The safety endpoint of death or dialysis was 48% higher in the invasive arm. Most notably, stroke rates were nearly 4 times higher in the invasive arm, and this hazard worsened over time. Now, Foy felt the juxtaposition of these two trials, ischemia and ischemia CKD, was unique. The lack of benefit and clear signal of harm in the invasive arm of the ischemia CKD trial bucks the prevailing notion that higher risk groups benefit more from intervention. Foy thinks it's the opposite, not only for coronary intervention, but for most therapies. Namely, people with competing causes of death stand to benefit less and be harmed more from treating just one of their many conditions. Next topic is Impella, and I'm going to start my discussion of Impella by saying 4 totally uncontroversial things about this device. 1, Impella is increasing in use. 2, Impella is costly. 3, Impella is invasive. And 4th, 2 RCTs for Impella in cardiogenic shocks showed no benefit, and 1 RCT for Impella for high-risk PCI was stopped for futility and did not show a significant reduction in 30-day mortality. So that's the background for 2 observational studies presented in a late-breaking sessions at AHA. Both these were observational studies from 2 different groups and each independent of industry funding. Both of these groups used different methodologies, and they both found a serious signal of harm from Impella use. Sanket Dhruva from UCSF, along with a team of researchers from Yale, used registry data to study patients with Impella versus balloon pump. They did propensity matching of 75 variables to get 2 groups of just under 1,700 patients each, who received either Impella or balloon pump. The rate of death in the Impella arm was 45% versus 34% for balloon pump. That's an 11% absolute risk increase. The rate of bleeding in the Impella arm was 31% versus 16% for balloon pump. Second study at AHA, Dr. Amin from Washington University in St. Louis presented this study, which was also observational but differed in methodology. Circulation published their paper. They used the Premier Healthcare database to analyze about 48,000 patients undergoing PCI with mechanical cardiac support. This was at 432 hospitals. Now, their approach was a bit of an ecological one, meaning they compared cost, utilization, and outcomes, say in-hospital mortality in the pre-Impella era versus the Impella era, and that is from 2008 to 2016. Now, as for trends in device use, Amin's group found sharp rises in Impella use in the last decade, but crucially, they also found greater than 5-fold hospital variation in its use. And that variation allowed the authors to compare outcomes in high versus low Impella use hospitals. And sit down for this. In an adjusted comparison of highest quartile Impella use hospitals versus the lowest quartile use hospitals, death and bleeding, kidney injury, and stroke were all significantly higher in hospitals that used the device the most. The authors also found more adverse outcomes in the Impella era compared with the pre-Impella era. Death was 24% higher, bleeding 10% higher, and stroke 34% higher, and all these reached statistical significance. So my comments on this is yes, I know these are observational data, so we can't say Impella caused worst outcomes, but my gosh, if these were positive data, they'd be being celebrated. You know that. Cardiologist and distinguished trialist Dr. Deepak Bhatt from the Brigham called these studies a red flag. Of course they're a red flag. First, it's plausible that Impella could be making things worse. It's a big device placed through a large bore arterial sheath in patients who are receiving antithrombotic therapy. It's hardly a stretch to say an intervention that increases bleeding in vulnerable patients could increase death. What's more, is it possible that fussing with a device could distract the operator and team from the job at hand, which is, of course, opening the blood vessel? At minimum, these observational studies, plus the null RCTs, plus the entire history of medicine, which is replete with similar failures of therapies that make sense, should vanquish the notion that there is not equipoise for mechanical cardiac support with Impella. Of course there is equipoise, and, in my opinion, it's well past time that we have an RCT before embracing this device. I've got a column on this topic, so I hope you take a look at it and leave a comment. Third topic is asymptomatic aortic stenosis. For my entire career, I have wondered about what to do with patients who have severe AS but tell you that they are okay. It scares you to keep watching these people because their valve is so bad on echo. But on the other hand, heart surgery is not nothing. It comes with risk. So years and years went by, but there's no data. Observational studies are not good in this space because there's just too much bias. Well, the uncertainty of this decision got a lot less uncertain here at AHA. South Korean investigators studied the question of early AVR or watchful waiting in severe AS with a multicenter RCT. They randomized 145 patients who had severe AS defined as an aortic valve area of less than 0.75 with either an aortic jet velocity of greater than 4.5 meters per second or a trans-aortic gradient of greater than 50. To be sure, these were patients who had severe AS. Their primary endpoint was a composite of operative mortality or death from cardiovascular causes during the entire follow-up period. The major secondary endpoint was death from any cause during follow-up. The results of this trial are extremely clear. Check this out. The point estimate of the hazard ratio was 0.09 for surgery. That is a 91% reduction over the conservative strategy, and the 95% range of this is from a 33% reduction to a 99% reduction in the odds of the primary endpoint. Death, too, from any cause occurred in 5 patients in the early surgery group and in 15 patients in the conservative care group, clearly significant. Now, the trick with this trial is not understanding the results. They're clear, but the application of the results. These were 63-year-old patients with severe AS, young patients, and it was surgical aortic valve replacement that was better than waiting, not TAVR. And the authors warned, correctly I think, that these results cannot be directly applied to early TAVR for asymptomatic severe stenosis. Next topic, colchicine. Here we go again with the inflammation theory. Recall that the general anti-inflammatory drug methotrexate did not reduce CV outcomes in the CIRT trial, CIRT trial. The more specific anti-inflammatory drug, canakinumab, did reduce non-fatal events, but by a very modest amount, a 15% relative risk reduction. At AHA, we heard results of the COLCOT trial, that's COLCOT, which was a placebo-controlled RCT, a comparison of low-dose colchicine given to approximately 4,700 patients within 30 days after MI. New England Journal published this trial. The primary endpoint, which was a composite, occurred in 5.5% with the colchicine group versus 7.1% of the placebo group. The hazard was 0.77, and the confidence intervals were significant. However, we have to look at what drove the primary endpoint. CV death, 0.8 versus 1%, not significant. Cardiac arrest, non-significant. MI, 3.8 versus 4.1, non-significant. Stroke was 0.2 versus 0.8, but they were very small numbers of events. The main driver was urgent hospital admissions for angina. Here it was 1.1 versus 2.1%. The secondary endpoints of overall death was no different. Now, the key opinion leaders were talking about this being a positive trial, but it's a very modest reduction in the composite endpoint. There was no reduction in hard endpoints like MI, CV death, or overall death. And while the stroke numbers favored colchicine, there were way too few events to make any sense of that. I did learn that the primary investigator, Dr. Tardif, said that there will be a COLCOT type 2 diabetes trial, which will be launched to study 30,000 people with diabetes without known coronary disease. Now, AHA did feature another colchicine trial, also with modest results. This was called the colchicine PCI trial, and it was led by a group at NYU. This RCT studied the use of colchicine loading 1 to 2 hours pre-cath, and investigators looked at PCI-related MI via the universal definition and the secondary endpoint of death, MI, or target lesion revascularization. They also looked at biomarkers in these patients. Now, they screened about 1,500 patients and ended up with only 200 patients in each arm who received the PCI and found no difference in the primary outcome, 118 versus 122 events, and a p-value of 0.19. colchicine did result in some reduction in inflammatory biomarkers after PCI, and I don't think either of these trials is enough to warrant colchicine use in patients with heart disease for prevention. Last topic is a treat to target to prevent stroke study. This was a late breaker at AHA and also had a simultaneous publication in New England. Right now, literally everybody who has a stroke in my hospital, whether it's from AF or whether the patient is non-ambulatory, get 80 milligrams of atorvastatin via a checkbox on the EMR. A multicenter trial in France and South Korea wanted to investigate the best LDL target for reduction of CV events after a patient has a stroke. Now, the previous big trial was called SPARCL, S-P-A-R-C-L, randomized patients with stroke to 80 of atorvastatin or placebo. Now, SPARCL enrolled 63-year-old patients who were ambulatory, did not have AF, and had an LDL cholesterol of at least 100, but no more than 190. And SPARCL showed a benefit, but it had a small effect size. The risk reduction in SPARCL in recurrent strokes was 1.9% over 5 years, and it just barely met statistical significance at 0.03. There was no difference in death or CV death in SPARCL. Now, the other point to emphasize was that the Kaplan-Meier curves in that trial do not separate for 2 years. So we don't have to slam people on high-dose atorvastatin right away. Nonetheless, I think this is the effect of what protocols do. So with that background, in the Treat to Target LDL trial, about 3,000 patients, also young, mean age 66, two-thirds men, with ischemic stroke in the previous 3 months or a TIA within the previous 15 days, they were randomized to a target LDL of less than 70 or a target of 90 to 100. Those were the two arms. All patients had evidence of cerebrovascular or coronary disease. The primary endpoint was a composite of MACE, ischemic stroke, MI, urgent coronary or carotid revascularization, or CV death. The follow-up was good at 3.5 years, but the trial was stopped for administrative reasons. I think it was loss of funding, and it was stopped after 277 of an anticipated 385 endpoints had occurred. The mean LDL was mid-90s in the higher target range and 65 in the lower target range, so really good separation there. The composite primary endpoint occurred in 8.5% in the lower target group and in 10.9% in the higher target group. That's an absolute risk reduction of 2.4%. The adjusted hazard was 0.78, and it was statistically significant. The lower LDL group reduction was done mostly by increasing the statin, but 1/3 of the patients had addition of ezetimibe. The components of the primary endpoint all went in the direction of the primary composite, lower with the lower target. Death was not significantly different. There were no increases in intracranial hemorrhage and no new cases of diabetes. A word on inclusion criteria. To be in this trial, patients had to have vascular disease. That included stenosis of an intracerebral blood vessel, atherosclerotic plaque of the aortic arch, or known history of coronary artery disease. Patients with AFib could be randomized, but only if they had the above disease. I like this trial because now maybe we can add some nuance to the treatment of these patients. If we can get a patient to an LDL less than 70, even if it's with less than 80 of atorvastatin, we know that we will reduce the composite of major vascular events, which makes sense. I still think we need to think hard about the external validity of these stroke trials. I mean, it hurts my heart to see elders who are barely ambulatory or cachectic put on high-dose statins. There's just no way we can translate these decidedly modest benefits to older patients and think we know that we're helping them. Finally, we have no evidence that a patient with AFib and no vascular disease who has an embolic stroke gets benefit from statins. So that's it for this week in cardiology. I know it was longer than normal, but gosh, AHA had a lot of studies. I'll be back in 2 weeks. Again, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell your friends. Consider subscribing and writing us a review so that others can find us. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.